Yeah. I was up in Michigan this week. Yes, in Traverse City. Questions? Has anyone got questions?
I always do.
Yes.
So I'm familiar with myostatin inhibitors. It's something we studied, decades ago. What sorts of, results would we expect in a human? Like more muscles, or I don't know if the clinicians can talk about that?
Basically, the answer to that is yes, more muscle, but myostatin is actually quite complicated, and it depends exactly what you're talking about. The one in the SMA clinical trial, agrigramop, I didn't have it said, that is supposed to not have off-target effects. It's meant to be very specific. If I'm sitting here and I'll just give my critique of it, to date, I'm not completely convinced because I haven't seen the trial done where the patient just gets the antisense and gets, or whatever treatment, and gets the antisense plus the myostatin, because those two have got to differ, and I don't really think there's any data that says that yet.
Yeah. So just to clarify, the two myostatin inhibitors that are going to be tested are going to be tested in children who have already had either gene therapy or SMN2 modification. So all of you know that once you have a treatment, you sort of plateau out. And the hope with myostatin inhibition is that it's not going to grow any new muscles, but the muscles that you have may become more functional. Or and I always use the analogy of a child I followed. She's now an adult, but she can bend her arm, okay, but she can't bend it quite high enough to brush her hair, so she doesn't have quite enough power to do that. So the range is there, but the power is not. So the hope is that a little more power would lead to more function. One of the drugs was tested very well in Duchenne, boys with Duchenne, and it did not work. But many of us predicted it would not work because in boys with Duchenne, the muscle is constantly turning over. And so they are actually getting weaker. Whereas children who have been treated with SMA tend to have a more stable course. And so we hope with repeated measures to be able to see, in a sense, for every trial, you are your own control, but we hope to be able to see a step up in either strength or function or both. But the two drugs they're two different ones, and they both work on a slightly different part of the exact same pathway.
Thank you, Bob.
Okay, so Dr. Kriener and researcher in Brazil is doing a study with Spinraza and valproic acid. Can you explain that to us?
Yes. Okay, so that study published in Cell recently, basically the idea is when you use the antisense oligo, it's going to switch the splicing. But a side effect of that mechanism is it turns down the expression of the SMN gene. So it's got a positive effect, which is switching the splicing, and a negative effect, which is turning down the expression. Adding VPA pushes it back up again, so it increases the expression. My argument would be, given the complications of VPA, I would, if it was me, I would prefer, I can never say that, risdiplam and the ASO overtaking VPA and Spinraza. Does that make sense? Does everyone understand that? Okay.
Right, because then they do back in the early 2000s, there was a valproic acid trial just for SMA.
Yes. So that was VPA on its own, but the difference here would be it'd be affecting. It's again working as an HDAC inhibitor, but I honestly don't think VPA is the optimal HDAC inhibitor. And the other one they use in that paper is TSA, but you could never use TSA in the clinic because it's toxic. So the translation of that, I think, is a little tricky, to say the least. If it was a straightforward HDAC inhibitor that had limited to no side effects, then I would be more positive on it. But I think it's more interesting from a mechanism point of view of why the antisense is doing that and how you can get over it than it is from a practical view of treatment. Would you agree, Anne? Yeah. Any other questions? Yes, Michelle.
Do you have any idea when Burghes Gene Therapy will start their IT program, IT trials for the last two Zolgensma? And if you guys are familiar with anybody like Dr. Waldriff, Dr. Connolly, if you know anything about that, I do know that it's like, but the type 2 and up. And
I mean, they renamed the trial and restarted it, is what I know. So it is restarted, but it's not recruiting at a very quick rate. And basically, if you ask me, Novartis needs a kick in the pants to get it going. But that's what I would say.
I mean, maybe that's too much.
So the hold, and the paper is going to be published on what they do have, but they decided as a company not to finish that last cohort with the higher dose.
Right, but aren't they doing two different ones? Like, I know they're recruiting at in Virginia with Dr. Proud, and then there's another one coming out, but they have no sites for it yet. Is that strength? I don't know. I can't remember.
Yeah, it's
the
got
name
the
of that.
strength.
I don't know what the name is.
Yeah, strong
Well, there's
strength.
like a phase
So,
3.
but
and
my
then a phase
understanding is
3A.
that they're going to do the same dose, the second level of the dose, that they have not committed to doing the third dose up. And so the issue with IT, the reason for IT is you can use a lot smaller dose.
Right.
So you can dose everybody who hasn't been dosed. The side effects were in non-human primates. They were not in any of the children. There were no side effects in any of the children. And as I was part of that study at Washington University, and the way you test for side effects is very careful sensory exams, and they had absolutely normal sensory exams, and the children were extraordinarily cooperative with that. So we would test things like vibratory sense and light touch, and it was and temperature. So there was never a side effect. But the FDA, because of the animal data, they constantly look at both. They put a halt to it, but then they reviewed everything and said they could continue, and the company made a decision not to do the next level up. But the study that you're talking about, I think, is a confirmatory one. Megan may know for.
I don't know much more about it. It's fear, I think, is what you're asking about.
Okay.
For type 2.
Yeah, I think it's like type 2s and like 3s, and all I know is it's a double blind. Both of them are double blind, and I know that one of them already has a site, and it's in Virginia with Dr. Proud. And
Yeah, and we talked about that, and we did not like the study design. We didn't feel like it was ethical or.
well, when you read the trial thing on clinical trial about it, I don't blame you.
Yeah, so we passed on that, because the placebo, first of all, we did not think we would be able to enroll in it, because with newborn screening and the other, and at this moment with all of our younger ones are all on some sort of SMN replacement, we thought a better approach would be to do an add-on with a completely different mechanism of action, and that's why we are in both myostatin. One of the myostatins allows kids who have had gene therapy, and the other one excludes them. So we wanted, we don't care who wins, but we think we wanted to make both of those available because we have a very large population.
Right, I agree with you, because, and when you read it in the clinicaltrial.gov thing, both of them literally said that you have to be, treatment naive.
Yeah.
Okay, and I'm
So
not
they're
sure
gonna,
how, I'm
so
not
they're
sure
gonna,
how you're gonna get
I
it.
think they're gonna end up doing those in other countries, is what I think is gonna happen.
Yeah, I mean, absolutely. I mean, that's ridiculous. I mean, that's not a design, and
Not,
I don't.
not in
Right.
2022.
Yeah,
Not
I
in
mean,
2022.
there's just no way that's a design. I mean, just to comment on the toxicology data from, you got to realize this, that the changes that we're seeing is basically inflammatory cells within the spinal cord that resolved over time. It's important that the latter is taken into consideration. And I think FDA got doubly nervous after the paper that appeared from the group in University of Columbia said there was tox when you overexpress SMN. But that's not the situation with Zolgensma. That doesn't occur. So I really think my feeling is that the intrathecal dose is a very good way to go in older patients, and basically the only way to go, because you can't put those massive viral doses into people. You'd have to do it completely different. I just don't think it's the viral vectors are there to do that through the bloodstream. That's my opinion.
So, like, another question, in Europe, they've decided to give Zolgensma to any age, but you have to have a certain weight. I can't remember what it is. I think it's like 21 or 22 kilograms, and there are 5-year-olds and 6-year-olds that are actually getting the Zolgensma.
Yeah, I know the Europeans push for it quite heavily. I was actually involved in some of those discussions. I would still vote against that risk. I mean, I just think it's too risky to increase viral doses to too high a level. I think the cutoff of 2 years of age and I can't remember what the weight is. It's, I think those weights, that is the maximum titer that I feel comfortable with.
Yeah, I think the company did disclose, so in a child in Russia and another one in Kazakhstan, who were, one of them was a lot bigger, and in both cases, the monitoring that we do, like the weekly monitoring, was not done. But the concern we have had all along and is that the FDA said 2 years. Well, at 2 years, maybe you're 25 pounds, maybe. But if you make it a 20 kilo cutoff, or was a 20 kilo cutoff, then it was yeah. Some of those viral loads, and especially if people didn't. Now, in other children, there are studies going on where we're giving that much vector in children with Duchenne, for example. But though in those cases, we are prepared, and we have seen side effects that have to be very carefully managed. And so there have been some toxicity in those studies, including a couple of deaths, not in Ohio, but in other studies, in other trials. So, I do think that we're still on a steep curve for how to do this safely.
Yeah, the other point I'd add is when you're doing this with muscle mass loss, that one of the target tissues that takes up the virus of AAV9 is muscle. So when you inject vascularly and you've got much less muscle, you're going to hit the liver harder. And so, you're riding a tight balance there. So I really don't think going into the vasculature in too larger children or too older children is a great idea. That's my feeling for it.
So guys, I'm Madison's dad. Stay here, Doc. So I gotta tell you, here's what's amazing to me, and that is that we started with a 5-minute diagnosis for Madison. Take her home, make her comfortable. How will she die? We won't go into the details of how she will die, but look where we're at now. And this is the guy, okay? This is, no, you.
Lots of other people, lots of
I
other
understand,
people.
but at the base level, right, I mean, through all this, you got it all started, okay? And we went to all these conferences, and all these people, and everybody told us how to raise the money, we raised the money, okay? But he's the guy, and everyone else that's followed, we appreciate all the work you guys have done, and all the parents here, I hope they all appreciate if their kids are doing a lot better from all this stuff. It's because of Arthur Burgess.
Well, thank you very much, but I think it's the team that did
Well, but it starts with you, brother. So thank you very much, everybody. Annette, you got anything left? Are you ready to?
you.
Megan has one more, Megan has one more thing.
Go for it.
All right, I just wanted to, again, say wonderful work to Dr. Burgess. Everyone here, it's an honor to be able to work here at Nationwide Children's. I grew up in Southern California. Everybody's like, why do you live in Ohio? And it's because of this job. But I did want to introduce, we have a new nurse practitioner who is amazing and is going to help really bring our clinic to the next level. And she's over there. Her name is Shannon. I can't say her last name. And so you guys will be meeting her throughout clinic. She's going to be seeing some patients on her own. As you guys know, in SMA clinic, we have, 4 providers now. We all try and rotate so you can see each of us in case one of us is out, just so you're comfortable and know that everyone is really kind of collectively managing the care. And we do meet as a group on Mondays every week to discuss treatments, concerns, questions from anyone. So we do really think of everyone collectively and make sure that we try and get everyone's insight and opinions to give everyone the best care possible. So thank you.
Okay, this is for the clinicians, this is for the SMA clinic.